Good morning. I want to also welcome you, all the ones here in the room and also the ones joining by web. And as Teresa said, this NHSN training is done in collaboration with our colleagues in CMS. So it's very important that CDC and CMS, we work very closely together, not just for data issues, but also for prevention, so we can really make a difference in the prevention of healthcare-associated infections. Also want to take this opportunity to thank you for all your work in the prevention of healthcare-associated infections and your commitment of learning more and being here today. When I was getting to the room, I saw many familiar faces and also saw many new faces. And I think this is a reflection of what is happening in the field of healthcare-associated infections. For the ones who have been doing that for a while, we know that in the past 10 years, lots have happened and in the prevention of healthcare-associated infections. And we've seen progress in the prevention in the hospitals. And we also, I think, have made a lot of progress. So NHSN data are being used not just by states with mandates, but also by CMS for value-based purchasing, and by all the HHS activities related to healthcare-associated infections. So it's overwhelming to all of us, but it's a way to be consistent. So the same source of data can be used by all the initiatives that really focus on prevention of healthcare-associated infections. With that, we move from having around 300 healthcare facilities participating in NHSN to 10,000 healthcare facilities now enrolled in NHSN. So it's a success, but also it's a challenge to all of us. But I think the more we work together, the more we can make a difference in what is happening in healthcare. And with that, consistency with definitions is, and also how we collect the data, are critical for how valid the data is going to be. And with data being used, again, not just for local prevention, but for regional initiatives, for state mandates, for value-based purchasing, we really need to focus on very good data and good definitions. Expanding reporting is another thing that we're seeing. As I said, initially, we had hospitals participating in NHSN and being involved in a lot of prevention initiatives for HAI. Now, I'm happy to see that we also have in this training the LTACs, the long-term acute care facilities, the IRFs, the inpatient rehabilitation facilities, and places where probably the type of procedures are not exactly the same as in acute care, but similar enough that can put patients at risk. And so we can use the same standards for surveillance and also for prevention. So working with CMS also has helped us to be more engaged with the quality improvement organizations. And I know some of you here are representing the QIOs. And also our work with the health departments has been extremely important. So not only you, the ones working in the facilities, can use the data for prevention, but the QIOs, the health departments, can look at the data not just for one facility, but what is happening in that state or in that specific region to really make a difference in how we're preventing infections. For you who is working in one specific hospital or LTAC, again, you see your patient population. What we're seeing at the national level is really encouraging us more and more to continue to really work together, because we are being able to, together, to prevent infections and also to promote healthcare safety. And last week, we had a meeting here at CDC with several consumer groups. And they are here bringing the faces of their family and their loved ones who had an infection, and many of them who died of an infection. And they appreciate all the work that we're doing, so fewer families have to go through what they've been through. And I think it's really exciting when I look around. I cannot see the ones joining by web, but I know also we have an audience there. And together we can, again, move towards better data and using the data for making a difference. We are always improving. I think it's part of what we do is always improving. And for NHSN, we're always improving. And what we do and the improvements that we are implementing are based on things that we learn here at CDC, but most of them are based on what you tell us, is your feedback to us that is really making us do all the changes that you are going to hear about. So as Teresa said, we're going to have some updates in 2013. Our main priority in terms of data collection is to simplify definitions, is to simplify data collection. So you can use the data for really making a difference in prevention. Our goal is to use more and more electronic data sources to help with surveillance. But at CDC, we're able to get the data, but many institutions are not there yet to send that information to us electronically. So it's a process that will go together, but that's the way we want to move towards. So continue to provide feedback to us because we do pay attention. Sometimes we don't move as fast as you like to because it's not just to address one healthcare facility or one type of setting. We have to really look at, when you look across, we need to really see what is the best that we can do to address all the issues that you tell us about, and also to address the work we do in collaboration with other agencies and partners. But as I said, we are going to see some improvements in 2013 and more improvements as we move forward. So continue to work very hard and providing feedback to us, but also using the data to make a difference in the prevention of healthcare-associated infections. Because at the end of the day, that's what we need to do in all levels. So I want, again, to welcome you to this training. For the ones who join in person, welcome you to CDC. And really hope that you enjoy the training. Use that for providing feedback to us. I know I don't need to ask you because it's something you're very good doing. But I really want to tell you our commitment and working together to make a big difference in what is going on in healthcare. So thank you and enjoy your training.
It is literally great to be with you because 48 hours ago, a gentleman ran a red light and slammed into my Honda. And so as my life was circling before me, the last thing I saw, of course, were my PowerPoint slides that I'm going to present to you. And any clarity that I can bring to the talk is a reflection of what a brush with serious injury or worse can do to one's thoughts, and any lack of clarity is due to the airbag deploying against the side of my head. So I'm safe. And it really is remarkable what we have available in the way of the technology for safety and in injury prevention, a field that I worked in for many years at CDC. There are a lot of lessons learned that are parallel in many ways to HAIs, and another time I would welcome an opportunity to talk about that. But what I'm going to talk about today is to build on what Teresa and Denise have already introduced, is we're growing NHSN and evolving NHSN in response to a changing environment. And globally, there is increased concern, both from a clinical and public health perspective, about HAIs, which of course have been around for a long time now, but they're better understood, and there's less fatalism about them, which in a sense is analogous to motor vehicle collisions as well. And countries have adopted various policies to prevent them, relying on a wide array of practices, and among them the publication of rates is important. In the United States is amongst a relatively small group of developed countries that not only publish rates, but also use those rates now increasingly to incentivize through financial mechanisms improvements of quality of care. So this is a major sea change in what's going on, and we reflect upon this all the time and what the implications are for our own environment and for HAI surveillance. Our assumption is that the advent of public reporting and the adoption of data-driven performance incentives are transforming the question of whether HAIs will be included in publicly reported metrics and pay for performance to when and how they will be included. And we think this is really a pivotal issue because what's at stake is a choice between two broad strategies for HAI surveillance, one in which individuals who are trained in case detection and use the entirety of the record that's available and other data sources to identify HAIs and submit numerator and denominator information to a system, and an alternative strategy in which individuals are trained to use discharge data from claims or administrative records to identify outcomes that are defined as HAIs. The former is more expensive, it's more time-consuming, but we think it's far more credible. And the bottom line for us and for you is that for HAIs, surveillance strategy 1 has gained favor over 2, but this preference is by no means permanent. And so many of the changes that we're making in NHSN, many of the reasons why you are joining us for this training today, have to do with a push forward on strategies that involve use of the entirety of the medical record that's available and use of trained individuals who can apply their knowledge and experience to the process of HAI surveillance. Basic terms, by public reporting, we mean the public disclosure of practitioner or facility performance measurements with the intention of improving transparency and accountability. Pay for reporting is financially rewarding practitioners or facilities for collecting and submitting performance data without actually differentially rewarding on the basis of the performance metric itself. Pay for performance, in contrast, is actually financially rewarding practitioners or healthcare facilities for scoring well on performance measurements, typically with respect to some ranking or some progress over time. A short history of pay for public reporting, pay for reporting, and pay for performance, it really only goes back about 25 years, and some of us are old enough to remember when HCFA first released Medicare inpatient mortality rates, unrisk adjusted, and got tremendous pushback for doing that. U.S. healthcare was the first health plan to initiate a large-scale pay-for-performance program. Then there was something of a quiet period of time before the early 90s when states began publicly reporting cardiac surgery mortality rates, followed by the National Quality Forum beginning to issue quality measure specifications for use in public reporting programs. NQF, for those who aren't familiar, is a semi-governmental entity in Washington, D.C. that endorses standard metrics for quality improvement and public reporting purposes. It doesn't create the metrics. Measure stewards, including we here at CDC, are responsible for creating and maintaining the metrics, but NQF approves them. Then CMS increasingly has been the driver with respect to pay for performance and pay for reporting. HAI data were first publicly reported by a state in 2005, and then 2 years ago, the Affordable Care Act established pay for performance, which is scheduled to begin next calendar year. There's been an overall policy shift in this whole realm of patient safety and quality of care from publicly reported serious events, which is advocated in the famous Institute of Medicine report in 1999 to err is human, where there's precious little to be said in there about reporting of HAIs or other than truly life-altering, life-ending events, to a broad use of report cards for payment purposes that's embedded in the Affordable Care Act, the Pay for Performance program that's going to be launched. That's also known as the Hospital Value-Based Purchasing Program. And in the Affordable Care Act, there's a section that calls for healthcare-associated infections reporting to begin in accordance with metrics that the Federal Department of Health and Human Services establishes and maintains in its action plan to prevent HAIs. And these metrics, in the first iteration of them, you can see have a preponderance of use of NHSN as the system for delivering the metric data. But it isn't across the board. In some instances, there's a call for use of hospital discharge data or the Emerging Infections Program data, another CDC state collaboration. So NHSN is our system for enabling surveillance of healthcare-associated infections. As Denise mentioned, we began actually 7 years ago this month with about 300 hospitals that were legacy systems from the NIST days to over 4,900 hospitals this calendar year and a total of 10,000 healthcare facilities. We have within the system numerators and denominators, outcomes that are risk adjusted, and measures that are endorsed by the National Quality Forum, the organization I described a moment ago. The data are used for a variety of purposes. And now actually this slide is up to date because we're up to 30 states and Washington, D.C. Operationalizing their HAI reporting mandates. CMS is using NHSN data for its pay-for-reporting programs and for value-based purchasing on the horizon. The technical design of NHSN enables manual data entry or electronic reporting via an industry-standard file format known as Clinical Document Architecture, or CDA, and about 10% of the hospitals participating in NHSN use that electronic reporting solution. Here are the NQF-endorsed measures, CLABSIs, CAUTIs, SSIs, healthcare worker vaccination coverage, the C. difficile and MRSA bacteremia, lab ID event proposed measures are well on their way to NQF endorsement. There are one or two more relatively low hurdles to pass. So by early 2013, we will have a total of 6 hospital-oriented HAI measures that are endorsed by NQF and used by CMS in its pay for reporting and eventually pay for performance programs. Here is a slide that summarizes the use of NHSN in 29 states, and CLABSIs are far and away the most frequently mandated HAI. All states that are using NHSN as the operational system require reporting of CLABSIs from some units within the hospital. SSIs are number 2, CAUTIs number 3, and MDRO and C. diff infections are gaining momentum. Here's a summary of the current and proposed reporting requirements for use of NHSN data supplied to CMS. And as you can see, we began in January 2011 with CLABSI reporting. That's been extended beyond acute care hospitals to long-term care hospitals. Ditto CAUTI. SSIs began earlier this year in January, colon surgeries and abdominal hysterectomies, with more events and vaccination coverage to follow. So what are the implications of all of this? Well, the environment is one that has rapidly transitioned within the 7 years that NHSN has been in existence. We began as a purely voluntary and confidential system, and we are now predominantly mandatory and public reporting system. The vast majority of healthcare facilities that have enrolled had not participated in the legacy CD system. Some of you had, most of you had not been part of the NIST program, so there's a lot of training and support that we're committed to providing to enable this all to happen. and happen as successfully as possible. The primary motivation for facilities to comply is the reporting requirements, but we are strong proponents of the notion that data that are used for external reporting should and can drive internal quality improvement. But to make that happen, we know that uncertainties about the quality and completeness of the data must be addressed and addressed forthrightly. So we are responding in part to simplify our definitions and data requirements because there's a close tie to data validity and move to electronic HAI detection and reporting as efficiently and rapidly as we can. The implications of all of this are that NHSN's purposes, infrastructure, and operations have changed. We've revised the very agreement to participate in consent form to reflect use of the data by state mandates and CMS reporting requirements. We've enhanced the infrastructure to improve system performance. We know it's not perfect. We hear from some of you from time to time, and as Denise mentioned, most of the changes we make are in response to user concerns and problems. There's new scrutiny of HAI case criteria and reporting requirements because the data are being used for these additional purposes. So we're responding with intense reviews and changes to our definitions and criteria, and you'll hear much more about all of this as the training goes forward. We're working closely with states and CMS on a validation program and are seeking to establish and maintain a nationally standardized approach to CLABSI validation and then additional HAI validation. And as we've emphasized, there is pressure to simplify our definitions and data requirements, and we're responding to that pressure with changes that we're making. So as we look at the big picture, are healthcare report cards and new payment policies a catalyst for change or a cause for concern? Well, we think they're both. That it's possible for the report cards and the payment policies to actually drive changes in clinical performance, but those are most likely to occur when the data are actionable, reliable, robust to criticism, and understood in broad term by significant stakeholders in the data beyond ourselves. Concerns about the report card and payment policies are most likely to be allayed when we've got safeguards against unacceptably burdensome reporting requirements, gaming of the data by providers, which is to say manipulation, which we know can occur, inappropriate focus on what is measured and incentivized at the expense of other important aspects of healthcare. And we see this when report cards are used in any domain, be it education, transportation, healthcare. If you focus on one metric or several metrics, what about the other aspects or facets of the service sector that aren't under measurement, and what attention are they getting in the midst of all the attention that the metrics are getting? And then above all, we want to avoid distortions of clinical priorities or practices. Diagnostic practices that are standard of care could be, in some situations and in some persons' hands, be distorted so as to avoid actually accumulating data that would confirm an infection. Summing up, we recognize that public reporting, pay for reporting, and pay for performance are part of a much larger trend toward more transparency and accountability in healthcare and in these other service sectors. NHSN has emerged as the primary surveillance system for reporting mandates at the state and federal levels. For us here at CDC, the main opportunities and challenges are to meet these rising expectations in ways that maximize the benefits for patient care and public health while mitigating risks for unintended adverse consequences. Thanks a lot. Happy to answer any questions or respond to any comments you might have. Please use the mic if you have either. Good morning. Yes, I can hear you. I'm not sure everyone else can, so I can repeat the question if it's not on.
My question has to do with data mining
Uh-huh.
and its application. My question has to do with data mining and getting information from other sources, so we would have more infections identified. And because we're comparing against the state and against the nation, is that a detriment or a help? Because a lot of our facilities are looking to get these data mining surveillance tools. Thank you.
Sure. So we think anything that can help produce higher quality, complete, valid data is an asset. And we've worked very closely with CareFusion, which is what MedMind is now referred to, and other vendor systems to enable, for example, that electronic reporting solution that I mentioned earlier to be constructed in collaboration with those vendors. We think the vendors can add tremendous value to the supply chain of the data, and even earlier in the supply chain where the data are mined to help IPs identify from candidate cases those cases that merit reporting. So we're keenly interested in extending our standards-based solution from the actual file format in which the data are delivered to earlier stages of the supply chain where the rules for identifying cases and populating numerator and denominator records can be operationalized in such a way that we have vendor-neutral, implementation-ready solutions. So we know more about what we're getting. Well, very good. We can use the extra time, and again, we're very grateful for your attention and being part of this here with us. So.